I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 2 of our 8-part series on menopausal hormone therapy, or MHT. In episode 1, we talked about what perimenopause and menopause are, what is happening to estrogen and progesterone, and why a single blood test cannot tell us very much about a woman's experience during the menopausal transition. Today, we're moving on to the question many people bring to the pharmacy, the GP surgery, or the specialist clinic. Will MHT fix what I'm experiencing? Because depending on where you get your information, MHT may be presented as either dangerously overprescribed or as the solution to practically every problem a woman develops after the age of 40, and neither version is particularly helpful. MHT is an extraordinarily effective treatment for some menopausal symptoms. It may improve several others, and there are some things it just cannot reliably treat and should not be prescribed solely to prevent. Understanding those distinctions matters. It helps women make informed decisions, it helps clinicians set realistic expectations, and it prevents us from declaring MHT a failure simply because it did not fix our symptom it was never particularly likely to fix in the first place. So let's begin with the symptoms for which the evidence is the strongest: hot flushes and night sweats. The clearest indication for systemic MHT is the treatment of vasomotor symptoms. That means hot flushes and night sweats. A hot flush is not simply feeling a bit warm. It can be a sudden wave of intense heat, often beginning in the chest, neck, or face, sometimes accompanied by sweating, flushing, palpitations, anxiety, or a sense of internal agitation. At night, these episodes may soak clothing or bedding and repeatedly wake the person from sleep. MHT is considered the most effective treatment available for menopausal vasomotor symptoms. For many women, the improvement is substantial. The flushes become less frequent, less intense, or disappear completely. Night sweats settle, clothing and sheets stay dry, and sleep becomes much less fragmented. But we should still avoid promising perfection. A woman may improve significantly without becoming completely symptom-free. The response can depend on the dose, formulation, route, adherence, and whether the symptom is actually being caused by menopause. It may also take some time to find the regimen that provides the best balance between symptom relief, bleeding patterns, and adverse effects. If symptoms have improved but not sufficiently, that may prompt a review of the dose or formulation. It does not automatically mean that MHT doesn't work. On the other hand, persistent drenching night sweats should not automatically be attributed to menopause, particularly if they are accompanied by fever, unexplained weight loss, swollen lymph nodes, infection symptoms, or other concerning features. Menopause is common, but it is not the only explanation for sweating. Sleep disturbance. Sleep is a little more complicated. MHT can improve sleep, particularly when poor sleep is being driven by hot flushes and night sweats. If someone is waking 4 times a night, drenched in sweat, treating the night sweats may make an enormous difference to sleep quality. But menopause-related sleep disturbance does not always involve obvious night sweats. Hormonal changes may influence sleep directly, and symptoms such as anxiety, palpitations, restlessness, bladder symptoms, musculoskeletal pain, and changes in mood can all contribute. MHT may improve sleep disturbance in some menopausal women, but the response is not as predictable as it is for hot flushes. And not every sleep problem arising in a woman in her 40s and 50s is caused by menopause. Sleep apnea, alcohol, caffeine, depression, anxiety, chronic pain, thyroid disorders, medicines, shift work, caring responsibilities, and primary insomnia may all be relevant. So when someone says, I started MHT and I still don't sleep, we need to ask a second question. What is keeping you awake? If the flushes have gone but she still lies awake for 2 hours worrying about work, increasing the estrogen may not be the answer. MHT can remove one obstacle to sleep. It cannot necessarily remove every obstacle. Genitourinary syndrome of menopause. Another major area in which hormone treatment can be highly effective is genitourinary syndrome of menopause, or GSM. GSM is the collective term for changes affecting the vulva, vagina, urethra, and bladder associated with declining estrogen. Symptoms may include vaginal dryness, burning or irritation, pain during sex, reduced lubrication, spotting or tearing with penetration, urinary urgency, frequency, recurrent urinary tract infections, phantom urinary tract infections, and discomfort when passing urine. Unlike hot flushes, which often eventually improve, GSM commonly persists and may worsen without treatment. Systemic MHT can improve GSM symptoms in some women, but systemic treatment is not always enough, and local vaginal estrogen may be required even when someone is already using an estrogen patch, gel, or tablet. For a woman whose primary problem is vaginal or urinary symptoms, low-dose vaginal estrogen may be more appropriate than systemic MHT. That distinction matters. Systemic MHT circulates throughout the body and is generally used for symptoms such as hot flushes and night sweats. Local vaginal estrogen is used in very low doses and acts predominantly in the vaginal and surrounding tissue. It may be supplied as a vaginal cream, tablet, pessary, or ring depending on what's available. Vaginal moisturizers and lubricants may also be helpful. Moisturizers are generally used regularly to improve comfort and hydration, while lubricants are used around sexual activity to reduce friction. But these products do not reverse the underlying tissue changes in the same way that local estrogen can. Clinicians should also remember that women do not always volunteer these symptoms. They may be embarrassed. They may believe nothing can be done. They may think painful sex, constant urinary urgency, or recurrent infections are simply an inevitable part of aging. Sometimes the most useful thing we can do is ask directly, but sensitively. For example, have you noticed any vaginal dryness, discomfort during sex, urinary urgency, or recurrent urinary infections? That one question can identify a problem a woman might be living with silently for years. Mood symptoms. This is an area where oversimplification can be harmful. Some women experience new or worsening low mood, anxiety, irritability, emotional volatility, or a reduced ability to cope during perimenopause. And these symptoms are real. They may be related to hormonal fluctuation, disrupted sleep, physical symptoms, life stress, or very commonly, some combination of all of these things. MHT may improve symptoms when they are associated with menopausal transition, particularly when they occur alongside other menopausal symptoms. A woman whose hot flushes, night sweats, and insomnia improve may feel dramatically better emotionally because she is no longer exhausted and physically uncomfortable. But MHT is not a universal antidepressant. It should not be assumed that all depression or anxiety arising in midlife is caused by menopause. Major disruption, bipolar disorder, trauma, grief, workplace stress, relationship problems, substance use, and other mental health conditions still require appropriate assessment and treatment. A person with severe depression, suicidal thoughts, profound functional impairment, or symptoms suggestive of mania require timely mental health assessment. It would be unsafe to simply prescribe MHT and wait to see what happens. MHT and antidepressants are also not mutually exclusive. A woman may benefit from MHT for menopausal symptoms and still require psychological treatment, an antidepressant, or other mental health care. The useful question is not, is this hormonal or mental health? It is, what factors are contributing and which treatments address each of them? Brain fog and cognitive symptoms. Brain fog is one of the most commonly discussed symptoms of perimenopause. Women may describe difficulty finding words, forgetting why they walked into a room, losing their train of thought, struggling to multitask, or feeling less mentally sharp. For someone who has always been highly organised and cognitively quick, this can be frightening. Some women worry that they have developing dementia. Cognitive complaints are reported during the menopausal transition, and MHT may improve them in some women, particularly when poor sleep, hot flushes, and mood symptoms are contributing. Australian clinical guidance acknowledges that MHT may improve cognitive concerns in some patients, but the evidence is less certain than it is for vasomotor symptoms. We should therefore avoid two extremes. The first is dismissing brain fog as imaginary. The second is promising that estrogen will reliably restore someone's concentration and memory. Brain fog may improve with MHT, but it may also reflect sleep deprivation, stress, depression, anxiety, ADHD, thyroid disease, anemia, nutritional deficiency, medicine effects, alcohol use, or another medical condition. And importantly, MHT should not be started solely for the purpose of preventing dementia. We will discuss long-term health claims in more detail later in the series, but the simple message is this. Treating distressing menopausal symptoms is a valid reason to consider MHT. Using systemic MHT as a guaranteed strategy to prevent Alzheimer's disease is not. Joint pain and neuromuscular symptoms. Aches and pains are extremely common around the menopausal transition. Women may describe stiff hands, sore hips, aching knees, shoulder discomfort, or the feeling that their whole body has suddenly aged. MHT may improve musculoskeletal symptoms in some women, but again, may improve is not the same as will treat. Joint pain can have many causes, including osteoarthritis, inflammatory arthritis, tendon disorders, injury, hypermobility, fibromyalgia, thyroid disease, vitamin D deficiency, and medicine-related effects. New joint swelling, redness, significant morning stiffness, muscle weakness, or progressive functional impairment warrants proper assessment. We should not assume every painful joint belongs to menopause. MHT may reduce a general background of menopausal aching, but it will not repair a torn rotator cuff or reverse advanced osteoarthritis. Headaches and migraine. Headaches and migraine may change during perimenopause because fluctuating estrogen can be an important trigger. Some women experience more frequent or severe migraine during the transition. Others improve after menopause once hormonal levels become more stable. MHT can help some women when hormonal fluctuation is contributing, but it can worsen headaches in others, particularly if the regimen produces fluctuating hormone exposure. Transdermal estrogen delivered through a patch or gel is often preferable in women with migraine because it can provide a more stable hormone level than oral therapy. Migraine is not necessarily a reason that MHT can never be used, but the type of migraine, vascular risk factors, and route of administration need to be considered. MHT is not, however, primarily a migraine medicine. A woman with a new, severe, sudden, or neurologically unusual headache still requires appropriate investigation. Sexual dysfunction. MHT can improve sexual discomfort when symptoms are being driven by vaginal dryness, tissue fragility, pain, poor sleep, or hot flushes. If sex no longer hurts, desire may improve, but estrogen is not a guaranteed treatment for libido. Sexual desire is influenced by physical comfort, relationship dynamics, stress, body image, mood, fatigue, medicines, illness, trauma, privacy, and many other factors. Some postmenopausal women with persistent, distressing, low sexual desire may be assessed for testosterone therapy, but that is a separate clinical decision. Testosterone should not simply be added because estrogen has not transformed someone's sex life. MHT may improve the conditions in which desire can occur. It cannot manufacture attraction, resolve relationship conflict, or remove every psychological and social influence on sexuality. Bone loss and fracture prevention. MHT does more than treat symptoms. It also reduces bone loss and fracture risk whilst it is being used. And this is particularly important for women who experience premature ovarian insufficiency or early menopause because they are exposed to lower estrogen levels for longer. In women with premature ovarian insufficiency, generally loss of ovarian function before the age of 40, Hormone therapy is often recommended until approximately the usual age of natural menopause, unless there is a contraindication. And the aim is not only symptom relief, it is to replace hormones that would ordinarily have been present to support bone health and broader health. But for a woman around the usual age of menopause, MHT is not automatically the first or only treatment for established osteoporosis. The decision depends on her age, fracture risk, symptoms, medical history, and whether she needs MHT for other reasons. And bone health still requires more than estrogen. Resistance training, weight-bearing activity, adequate protein, calcium, and vitamin D where appropriate, avoiding smoking, moderating alcohol, and reducing falls risk all matter. MHT can help preserve bone density. It does not make strength training optional. What MHT does not reliably treat. Now let's be explicit about some of the claims that commonly circulate online. MHT is not a weight loss medicine. Body composition and fat distribution often change during midlife. People may notice more abdominal fat, less muscle mass, and that previous strategies no longer produce the same results. Menopause may contribute to changes in fat distribution, while aging, sleep, activity, diet, alcohol, medicines, and loss of muscle mass may also play important roles. MHT is not approved or recommended as a weight loss treatment. It may indirectly help someone become more active by improving sleep, flushes, joint discomfort, or mood, but it does not reliably produce significant weight loss. A woman should not be told that failure to lose weight means her MHT dose is too low. And MHT is not a universal treatment for fatigue. Fatigue may improve if it is being caused by night sweats, insomnia, or the relentless physical burden of menopausal symptoms. But fatigue also has a broad differential diagnosis. Anemia, thyroid disease, sleep apnea, depression, infection, diabetes, inflammatory illness, medicine effects, nutritional deficiency, and many other conditions can cause fatigue. Persistent or severe fatigue deserves an assessment, not an automatic escalation of estrogen. MHT is not a guaranteed treatment for hair loss or skin aging. Estrogen affects skin and hair biology, but systemic MHT should not be prescribed solely as an anti-aging treatment. Hair thinning may be influenced by genetics, iron deficiency, thyroid disease, stress, rapid weight change, androgen-related hair loss, autoimmune disease, and other factors. Likewise, MHT does not replace sun protection, treatment of dermatological disease, or evidence-based skincare. It is a medical treatment, not a cosmetic fountain of youth. MHT is not contraception. This is a very important practical point. Standard MHT does not reliably suppress ovulation and should not be considered a contraceptive. A woman can be perimenopausal, have irregular periods, and still ovulate unpredictably. Contraception is generally required for about 2 years after the final menstrual period, when menopause occurs before the age of 50, and for 1 year when it occurs at or after the age of 50. The exact contraceptive choice needs to account for age, bleeding, symptoms, medical history, and personal preference. A levonorgestrel-releasing intrauterine device may sometimes provide contraception and endometrial protection as part of an MHT regimen, but that requires appropriate selection and prescribing. MHT should not be started solely to prevent cardiovascular disease or dementia. That does not mean it has no effect on those risks. For a healthy symptomatic woman who begins MHT before the age of 60 or within about 10 years of menopause, the cardiovascular balance is generally more favourable than it is for someone commencing treatment much later. Some evidence suggests that certain regimens may reduce coronary heart disease risk in appropriately selected women, while other formulations may slightly increase the risk of stroke or blood clots. But we cannot tell every woman that taking MHT will reduce her personal cardiovascular risk. Her baseline risk, age, timing, dose, route, and type of hormone all matter. And MHT does not replace treatment of high blood pressure, cholesterol, diabetes, or smoking. Setting realistic expectations. So how should we talk to a woman who is starting MHT? We might say, MHT is particularly effective for hot flushes and night sweats. It may also help sleep, mood, aching, and cognitive symptoms, especially when those problems are connected to the menopausal transition. But not every symptom responds in every person, and we should still investigate symptoms that are persistent, severe, or unusual. That is not undermining the treatment. That is good counselling. We should agree on what we are trying to treat before therapy begins. Is the main goal to reduce 10 hot flushes a day down to 1 or 2? To stop waking drenched at 3 a.m? To make sex comfortable again? To improve enough sleep that the person can function at work? If we do not define the problem, it becomes difficult to judge whether the treatment has worked. Follow-up is also essential. Has the target symptom improved? Are there adverse effects? Is the woman experiencing unscheduled bleeding? Is the regimen practical? Is she using it consistently? Has a new symptom emerged that requires investigation? And does the balance of benefit and risk remain acceptable to her? MHT is not a one-off prescription followed by 10 years of autopilot. It is an individualized treatment that should be reviewed and adjusted as circumstances change. The central message from this episode is that MHT is neither a miracle cure nor a treatment we should be afraid of when used appropriately. It is the most effective treatment for menopausal hot flushes and night sweats. It is highly useful in the management of genitourinary symptoms, although local vaginal treatment may still be needed. It can prevent bone loss and reduce fracture risk whilst it is being used. And it may improve sleep, mood, cognitive complaints, and musculoskeletal symptoms in some women. But it does not guarantee weight loss, restore libido in every person, cure all fatigue, reverse every painful joint, prevent every chronic disease, or make the normal process of aging disappear. The question is not simply, does MHT work? The better question is, what are we asking it to do? Because when we match the right treatment to the right symptom and set realistic expectations, MHT can be genuinely transformative. Here are some reflective questions. Which menopausal symptoms are most likely to respond well to MHT? Which symptoms may improve with MHT but should still prompt consideration of other possible causes? How would you explain the difference between systemic MHT and local vaginal estrogen to a patient? Why is it important to agree on the main treatment goals before starting MHT? How would you respond to a patient who expects MHT to cause weight loss, prevent dementia, or eliminate their cardiovascular risk? What red flags would make you investigate symptoms such as night sweats, fatigue, joint pain, or cognitive changes rather than attributing them automatically to menopause? How could you sensitively ask a patient about symptoms of genitourinary syndrome of menopause? After listening to this episode, is there a symptom you previously assumed MHT would or would not treat that you now view differently? Across this series, we'll be talking about 3 key hormones: estrogen, progesterone, and testosterone. Think of them as a girl band, each with a different role, a different sound, and a different reason for being on stage. Beyoncé is estrogen, the headline act at the center of most MHT conversations. Adele is progesterone, less flashy but essential for balance and protection. And Pink is testosterone, powerful, sometimes misunderstood, and often left out of the conversation altogether. In the next episode, we'll start with Beyoncé and look at estrogen, what it does, the different ways it can be given, and how patches, gels, and tablets compare.